everyone. This is Frank Lattuca. I'm the PGY2 Oncology Pharmacy resident at the University of Rochester. Thank you for listening in. Today I'll be chatting a little bit about my poster titled The Evaluation of Bleeding and Venous Thromboembolism Events in Cancer Patients Taking Direct Oral Anticoagulants versus Low Molecular Weight Heparin. Just a little bit of background on this topic. Venous thromboembolism is 4 to 7 times more likely to occur in patients with malignancy versus those without. Approximately 4 to 20% of patients with cancer will experience a VTE at some point in their disease progression. On the other hand, bleeding events occur in up to 10% of patients with advanced malignancy and can also be a large contributor to mortality and can make the management of VTE in these patients very difficult. Current guidelines prefer the use of low molecular weight heparin for the treatment of VTE in cancer patients, as there is limited data for the use of DOACs in this population. DOACs are a promising option for some patients due to the ease of administration and lack of routine lab monitoring. Current evidence surrounding DOACs show relatively low rates of VTE recurrence. However, this is also associated with increased rates of bleeding. So the primary objective of this study was to evaluate the incidence of major bleeding in cancer patients taking DOACs or low molecular weight heparin. Some of our secondary outcomes include the incidence rate of first VTE recurrence, the incidence rate of dose modification of DOACs based on prescribing information at baseline and time of adverse event, incidence rate of bleeding events in patients taking concomitant antiplatelet agents and or medications with significant drug interactions, as well as mortality rate of patients who had major bleeding events. For our methods, this study was approved by the Institutional Review Board at the University of Rochester. It was a retrospective chart review that took place between July 1st, 2015 to June 1st, 2019. We had 622 patients who were screened, and our inclusion criteria were age greater than or equal to 18, inpatients or outpatients at the University of Rochester, active malignancy, diagnosis of VTE requiring treatment, and at least 1 day of treatment dose of anticoagulant. Our exclusion criteria was the use of low molecular weight heparin based on our URMC VTE prophylaxis guidelines. We ended up including 261 patients in our analysis and excluding 361. For our statistical analysis, we calculated the incidence rate of bleeding and recurrent VTE calculated as the number of bleeding events over the number of person years at risk. We used a mixed Poisson model to assess the change in incidence between groups. This model allows us to account for correlations between data coming from the same patient and the varying amounts of person time contributed within each risk period. As far as our baseline demographics, our median age at baseline was 64, and the sex categories, so male was about 53%, female about 47%. The majority of our patients had an ECOG status of 0 to 2, and our most common cancer types included lung, pancreas, colorectal, and non-Hodgkin lymphoma. Others are listed here. And we also listed a breakdown of which DOACs patients were on, most commonly apixaban and rivaroxaban. Looking at our other results, I will refer you to Table 2, which outlines our major bleeding events reported as the incidence rate per 100 person years. As you can see in the chart, there were a total of 21 major bleeding events. 15 occurred in patients who were taking low molecular weight heparin, and 6 occurred in patients who were taking DOACs. Right below it, in Table 3, we report the incidence rate of recurrent VTE events, again reported as incidence rate per 100 person years. Again, as you can see here, there were 5 recurrent VTE events, 3 were in patients taking low molecular weight heparin, and 2 in patients on DOACs. Looking at Table 4, this looks at the incidence rate of major bleeding, which was our primary endpoint, and reports the incidence rate ratio for patients who are on a DOAC versus those who are on a low molecular weight heparin. And as you can see, our incidence rate ratio was 0.68. However, what we found was that the p-value was not statistically significant between these groups. Some other things of note: Figure 1 at the bottom outlines bleed type or bleed by type of malignancy, our most common types being pancreatic, brain, and lung cancers. You can also see that this is broken down by which patients were on low molecular weight heparins and which were on a DOAC at the time of bleeding. I'll also refer you to Figure 2 up in the top right. This looks at the amount of follow-up that was contributed within each group. And as you can see, our low molecular weight group had quite a bit more follow-up than our DOAC group. So looking at our discussion section, I wanted to point out a few more things about some of the bleeding events, some of our secondary endpoints. So 4 of the 21 patients who had a major bleed, about 19% were on an antiplatelet agent at baseline. However, patients who were on an antiplatelet agent did not appear to have a statistically significant higher incidence of major bleeding. Of the patients who had major bleed while on a DOAC, none of them were found to have significant drug-drug interactions. And 5 of the 21 patients who had a major bleed, 23.8%, died. 3 of them were on a DOAC and 2 were on low molecular weight heparin. So our major conclusion from the study is that there was no significant difference in incidence rates of major bleeding or recurrent VTE between the different anticoagulant classes. These results suggest that DOACs are a safe and effective alternative to low molecular weight heparin for patients with cancer. We do list several limitations to this study as well. First and foremost, it is a retrospective study, so we only have data from a single institution. Additionally, we were only able to capture bleeding events as well as VTE events that were recorded in the electronic medical record. However, it's unlikely that this limitation would have caused us to significantly underestimate the incidence of major bleeding or recurrent VTE due to the fact that these events are of high acuity and likely require medical intervention and documentation. Another limitation is that there were more person years of follow-up in the low molecular weight heparin group versus the DOAC group. Our statistical analysis was able to account for the differing amounts of follow-up between these groups by reporting the bleeding and recurrent VTE events as an incidence rate per person year of follow-up. However, our results could have been more robust if the amount of follow-up in the DOAC group was more comparable to that of the low molecular weight heparin group. Thank you very much for listening in, and please feel free to reach out to me with any questions or feedback. Thank you. I hope you have a great day.